Okay. Good evening, everyone.
Go ahead.
Okay. So, good evening, everyone. Thanks for joining in. I would like to thank everyone, Gujarat NNF, and all the panelists and everyone who has joined in. As everybody knows, and we do have some international logins also. The people from various parts of this world, especially from Asia, has also been joined in. So I thank our panelists, Dr. Pradeep Suravanshi, so Dr. Srinivas Murki.
Mohit, you are muted. Please unmute yourself.
So as you must be seeing, I thank everyone for joining in. All of our panelists, Dr. Pradeep Suravanshi, Dr. Srinivas Murki, Dr. Dinesh Kumar Chirla, Dr. Ashish Mehta, Dr. Naveen Jain, Dr. Manoj, and everyone to be here. Because why we have chosen this, as you can see on the screen, it is now Neonatal COVID 21. And now it is very rightly being said like that because COVID-19 is gone now. Because now the strains we are facing everywhere are different. In Western India, I don't know, we will discuss in the panel, we have seen a lot of very sick babies and mortalities also because now the strain which is prevalent in Western, especially in Maharashtra and Gujarat, is UK variant, which is double mutant. And that this is what they are calling as Indian mutant, Indian variant. In North India, it is UK, which is UK variant, but not mutant. In South India, it is mostly the South African variant. So that's why they are calling it now neonatal COVID 21. Guidelines for the stable babies have been there everywhere. But what we saw in the last 1 to 2 weeks was a very bad scenario in newborn COVID. And we had 4 mortalities in Surat. That's why I just thought we should have a discussion and share our experiences so that the people, everyone should come to know that these type of things are happening and we should get ready by ourselves. Dr. Vardhan is there. He is our treasurer for Gujarat NNF. And Dr. Snehal Desai, he is the secretary for Gujarat NNF. So we will start with this. And I would say now the situation is so bad as we have talked about. Everybody talked about in last 5 minutes. The situation is so bad. So I remember our first wave, initial 1 year back. One of our very intelligent citizen of our country, she came forward and gave us a very good mantra how to tackle the COVID. And I think so that is the best that now we could do that. So this is the only thing we could think at present. We should request Corona to go. So I would request I would request Snehal to please introduce our panelists one by one. So after your introduction, there are slides which have been provided by the panelists to share their experiences for 1 to 2 minutes. They will share their experiences of wave one and wave two. And Dr. Snehal, please introduce. Then Dr. Pradeep Suryavanshi can share his experiences.
Yes, Nehal, please unmute yourself. You are muted.
Thank you so much. We realize how important this topic is because within 5 minutes, we have almost 220 people entering, already joined us, and almost 10 ml are in the waiting room. Can I request Dr. Vardhan to take care about the entering of the people? So what we will do is we have a galaxy of speakers from the length and breadth of India. We have heard them all over in our conferences. All of them are big teachers. After the introduction, 2 to 3 minutes to each of them to share their experiences, and then we will go on to the panel discussion. So let me introduce Dr. Pradeep Suryavanshi. He is the head and professor of Department of Neonatology, Bharatiya Vidyapeeth Medical College, Pune, and he is also the head of Sahyadri Hospital, Pune. We know his special interest is in point of care ultrasound. Please go ahead, Dr. Pradeep.
Do you have my slides or should I share my slides?
Yes, sir. I
No,
have.
Doctor.
So I would just add on to your introduction. Like today, all these Babas are here because as we have already talked, that only the Babas or something like Go Corona Go can tackle this Corona. So I would call him Baba Functional Eco Wale. So he will share his experiences. Yes, sir. Please go ahead.
Okay. Thanks, Mohit and Snail. Now I have taken out the cases in the last mainly 1 year, because in Pune city we started these cases from the month of July. So these are the 4 cases we have encountered in the first wave, and the common features: family history positive. The first wave, if you see these cases, they were actually presented as a respiratory distress on the day 1, day 2, and the day 5. That's the respiratory distress. But surprisingly, one patient presented on day 10 with the convulsion and with the features of encephalitis. The problem that time we encountered is actually the RT-PCR was negative in these 2 patients, but a classic happy hypoxia, distress, requiring ventilation, CT scan suggestive of classic features, and very, very high markers. If you see, the markers were very high, and we did require these babies, basically the methylprednisolone for these babies the last time. The one baby we just managed simply for basic oxygen. That was the first wave we have encountered. Mainly these are the 2 babies with the, basically 3 babies with the COVID antibody positive, and 1 was RT-PCR positive. But this time, next slide please, Mohit sir.
Yes, sir.
This time, these were the 5 additional cases, and 2 more added basically in the last 5 days, but they are not discharged, so I have not included them here. So this time, these are the cases. All these 5 cases are from the 25th of March till the 20th of April. I have not added 2 more cases which are still just now there. This time, whole families are coming positive. That means the parents, grandparents, all are positive, and babies, what we observed, are having presented with the typical fever. Fever lasted for 3 to 5 days, and surprisingly, the 4 babies and the 2 admitted babies, 6 babies have COVID antigen positive. That means you can see the high rates of infectivity. The naturally RT-PCR positive, but you can see that naturally the markers, we have done the markers these babies on day 1, day 4, and day 7. The markers were high in these 3 babies. Naturally, the good thing happened. Those were actually the 2 doctors. Case number 5, family's doctor, and the case number 9, also the family's doctor. Only thing is that this one, which we just managed with the paracetamol, but those other patients with high markers, we also required steroid therapy. The last time we required the surfactant, also bad high frequency ventilation. This time, luckily, in the last 7 cases, I haven't required the ventilation at present moment. The markers what we are doing at present moments are routine adult markers like CRP, interleukin 6, ferritin, LDH. These are the ones we are doing on admission on day 4 and day 7. If the markers are very high, we are adding the steroid. If there is a oxygen requirement, if there is a non-invasive ventilation, then we are giving those methylprednisolone. And naturally, 2 babies we have managed with the required the phenobarbital for controlling the convulsions. So this is the overall scenario. So the babies who are high grade fever with high markers, we are giving dexamethasone. Babies with a naturally high grade fever, high markers with oxygen requirement, with non-invasive support, we are selecting methylprednisolone. Nothing specific protocol is there, but this protocol we have done on the basis of the adult medicine, and that is what we are using. If the D dimers are very high, we are actually using the low molecular heparin also. So these are the 4 mainstay of treatment we have at present moment done. So this is what I would like to say from my side. But I would say the next slide. The first wave we had suspected maternal transmission. I said suspected because we didn't have RT-PCR positive. but there was a clear cut scenario about the presentation. The second wave, we have mainly seen postnatal transmission. That means positivity after day 5 of life. All family members, or 90% of family members are positive and COVID antigen positive. The fever is the main presentation in the second wave, and 2 babies presented with the convulsion. And naturally, one person has asked, have you ruled out the sepsis? Naturally, those things you have to always rule out RDS and sepsis when you are dealing with these cases. And we are using paracetamol and steroid at present moment main therapy. So that is data from my side. So we have these 9 plus 2, 11 cases at present moment from the 3 hospitals which I am visiting, the Bharti, Sahyadri, and Noble. So these are the data from these 2 waves from my side.
Yeah, thank you so much. Can I make a suggestion? We will have a panel discussion later on, and we will also have a question answer session later on. So I understand that we don't have guidelines. So the whole idea of Dr. Mohit Sahani to get all the galaxy of speakers is to find out what everybody is doing in their units and try to formulate some guidelines or some way by which everybody else can treat their own patients. So let us not ask too many questions right now. First, we'll go through everybody's experience. Am I right, Dr. Mohit?
Yes, please. And
Yeah,
Vardhan,
so-
you please take care of this administrative issues allowing people into this. I made you the co-host. Yes, Snail.
Yes, sir.
Yes.
Yes.
Yes. Again, Dr. Srinivas Murki, we have been hearing about him since when I was a student 10 years back in my fellowship. Dr. Murki is a DM neonatology from PGI Chandigarh. He is right now a consultant neonatologist at Paramita Children Hospital, and he's got a lot of teaching publications. Apart from that, a lot of YouTube videos from which all of us listen to while studying for neonatology. Dr. Srinivas Murki.
अनम्यूट कर देना, मैंने म्यूट किया है, अनम्यूट कर दो ना, स्नेहल अनम्यूट कर दो.
Yeah, I think
Yes.
so.
Doc-
Thank you.
Yes, Dr. Srinivas.
Yeah, so
Also,
Snehal.
what we will do is we will be muting everyone. So all the speakers, can you please unmute yourself when you come out to speak? Dr. Srinivas Murki is one of our very favorite teachers. He has a lot of YouTube videos teaching a lot of neonatology topics. Apart from that, the formal introduction is he is consultant at Paramita Children Hospital, and he has significant research publications.
So
Please go ahead, sir.
So this is our CPAP Wale Baba ji. Please, sir. Murki sir.
Sir, may I request you to unmute yourself? Sir, may I request you to unmute yourself?
Yeah, can you hear me?
Yeah.
Thank you, Snehal. I think, yeah, but I would like to go on a much more positive note. I think at least in Hyderabad, whatever we are seeing is more of adult and pediatrics. And we are yet to see a lot of COVID positive symptomatic babies in the newborns. I think for many of the newborns, COVID has been a bystander in the first wave. Whatever illnesses we are seeing, and incidentally, COVID was picked up because some family member or a mother was positive. And we had reported from Neonatology Forum the entire scenario of COVID in the newborns in this Indian pediatrics. I will share part of that first, and then I will go on to show some other things. So I think Dr. Diorari, I think I'm seeing him somewhere here, so maybe you can allow him. Dr. Diorari was instrumental in forming this registry, and last year, nearly 1,700 COVID babies we have identified, either born to COVID positive mothers or babies who were COVID positive by themselves. So we did compare babies who were COVID positive versus babies who were born to COVID positive mothers. And this is the, if you allow me to share, I will show you what findings we had in the Indian pediatrics from
Yes,
the
sir.
last wave.
Sure, sir. I will do this.
Yeah, I'm able. Can you see the slides?
Yes, sir.
Yeah, so this is the report I'm talking about. It is come out in Indian Pediatric, and you can check on this month. So it is published in Indian Pediatrics, and again it reflects the entire year of COVID one wave. We are yet to see the details of COVID 2, but I will try to highlight some of the things from this study, where you see that nearly. So you can see here that nearly 1,300 babies were enrolled in this registry, out of which all these babies were born to either COVID positive mothers, or family members were COVID positive, or babies themselves were COVID positive. So among the inborn babies, because this reflects the population dynamics or population demography, will be easier when you look at the inborn babies. If you look at this, among the inborn babies, 143 were COVID positive and 1178 were COVID negative. And look at these babies. The most striking thing is, obviously the risk of prematurity was higher in these babies. More babies who were born between 34 to 36 were COVID positive, and less than 34 also you can see more babies were COVID positive. Mode of delivery did not differ, mother positivity did not differ, rooming in with the mothers did not differ between COVID positive babies and COVID negative babies. Breastfeeding did not affect the COVID positivity. So rooming in, breastfeeding did not affect the COVID positivity in the newborns in the first wave. Now, among the symptoms, if you see, definitely whatever symptoms you see in newborns, they were all higher in babies who were COVID positive. Whether it is incidental or whether COVID was acting as a bystander, we don't know. But the number of babies who were COVID positive, the resuscitation was higher, symptoms were higher, and the symptoms typically we see in newborns like RDS was significantly higher. One important thing is, yes, pneumonia was most significantly higher in babies who were COVID positive. Sepsis rates were higher, seizure incidence was higher, septic shock was higher, DIC was higher, and abnormal chest X-ray findings were higher, need for oxygen requirement was higher, CPAP and ventilation requirement was higher. So I don't know whether it is a COVID which has led to see this symptom, or COVID was acting as a bystander. As I said, in the first wave, whatever symptoms were there in the babies were significantly higher in babies who were COVID positive versus babies who were born to mothers with COVID positive, but they themselves were COVID negative. And when we looked at the outborn babies, also similar picture was seen. So babies who were COVID positive had significantly more prematurity and more symptoms. However, breastfeeding rate, rooming in was not different between babies who had COVID positive versus COVID negative. So we gave a conclusion from this study that yes, COVID does transmit in the babies from the mothers. The risk of transmission was slightly higher than the Western world. Western world said it is less than 2%. And from this study, it was anywhere from 6%. But I doubt this figure, because for perinatal transmission, we have taken first 72 hours instead of first 12 to 24 hours. So maybe there must have been some horizontal transmission rather than perinatal transmission. The second point which we made from this study was, yes, there are babies who are COVID positive in the initial phase or coming from the mother to the baby, but this was not from breastfeeding or not from rooming in. Mostly it must have been respiratory way of transmission by then. Now that was the COVID-1. We are yet to see a lot of babies. We have just started seeing in our unit at least COVID positive babies coming with born to COVID positive mothers, but I have not seen yet symptomatic babies or babies who are newborns who had come with COVID positive symptoms. Last year we had 3 cases of pneumonia which presented slightly delayed. So these babies came from home mostly after the first 1 week of life, where they had typical pneumonic symptoms, and all of them improved with just symptomatic management. We did not have to use, apart from routine oxygen, CPAP, HFNC, and ventilation, we did not have to use remdesivir or steroids for those babies, at least in the first wave. This year, I'm yet to see a COVID pneumonia in the newborns, maybe because we are in the beginning phase of this COVID-2, and I don't know how the scenario is. Maybe Dinesh can throw more light because his hospital is COVID positive. He takes care of COVID positive newborns from the beginning and now on. Now, the important thing is, yes, all of us need to document things. We need to have some protocolization from the beginning so that we know how we are doing at the end of the day. So the INNC COVID registry or the newborn NNF COVID registry is available for all of you. We are just going to add the multi-system inflammatory response also into the registry. So please use the registry and give your data so that at the end, at least in few months from now, we will be able to give a better guideline. At least we can form a more strong evidence-based guideline for the management of babies for COVID. So that's what from my side. But in pediatrics, yes, we are seeing COVID symptoms in pediatric babies. I know our pediatric colleagues have seen COVID pneumonias, COVID diarrheas, and COVID as a bystander in dengue patients. And very recently, we have seen a COVID positive child who presented with benign intracranial hypertension with papilledema and bilateral sixth nerve palsy. So I can tell you that yes, these symptoms are going to come in newborns, but the time has come for us all to get together, get our act together, start enrolling in the registry so that we can make an informed decision. If not now, maybe a month later, we can all sit down together again and see how we can manage our babies better. Over to you, Snehal.
Thank you, sir. Snehal. Snehal.
Yes. Thank you very much, Srinivas sir. May I now request Dr. Dinesh Kumar Chirla to share his experience. He is one of the very few people who have done 2 fellowships, fellowship in neonatology from Australia and fellowship in pediatric critical care from UK. He is as active in pediatric critical care group as he is in neonatology. He is the director and neonatal of intensive care, both NICU and PICU at the Rainbow Children's Hospital and perinatal care. We'll have some words of his experience because he's been doing COVID since a long time. Over to you, sir.
So he is a Baba of hospital chains. Welcome, sir. Please.
Thank you, Mohit and Snehal. Can you hear me? Yeah. So
yes, sir.
I think we can see a very contrasting view thing between the first wave and second wave. And as Murki has been saying that we were taking care of the COVID positive mothers in the first wave and now again in the second wave. So in the first wave, I know if you look at right from sort of April till December, then we didn't see much. We had 16 COVID positive mother who delivered with us, and out of which only 5 newborns turned positive. Was one interesting case, one was a 27 plus 4 week baby who delivered because of mother went into spontaneous preterm labor. She was COVID positive. The child had to be intubated and ventilated for RDS. Extubated on day 2, was put on CPAP. Somehow on day 5 started having again worsening distress, apnea, bradycardia, so had to be re-intubated. On assessment, he was found to have very poor myocardial function. The first because mother was COVID positive, we did take the endotracheal aspirate for RT-PCR and it was positive. Yes. So because there was a child who had sort of deteriorated, we did an echocardiograph which showed poor myocardial function and showed a very raised inflammatory markers. IL-6 was raised, the pro-BNP was raised, and the ferritin was raised. And it was very, little bit tricky about how do we deal, especially in the first wave with the child with the raised inflammatory marker, poor myocardial function, because at that time, MISC was something which we were seeing in the pediatric age group. So it decided, okay, this was child was showing myocardial involvement, raised troponin was also raised. So decided, and when you see echo, I'm sure there are 2 big functional echo guys here in the group, both Mohit and Pradeep was there. I was asked to share on one slide, so otherwise I would have shown you those echocardiograms. There was significant matter regurgitation and poor cardiac function. So we decided to go IV immunoglobulin, but hesitant to give steroids considering the prematurity and long term. The child seemed to have settled down temporarily and then, was fine for a few days and we were able to come down on the respiratory support, but again started showing the raised inflammatory markers. And that is when, the ferritin was over the roof. And that's when we decided to give steroids. And of course, we will talk about it, the steroids, when we have our actual panel. So we decided to go ahead with dexamethasone this time. And once we gave Dexa, the child started improving significantly. We were able to come out. All the markers came down. Though one thing which we found in a lot of these COVID positive babies was the D dimers were elevated. Considering the prematurity, we were hesitant to give anything like heparin because of the risk of bleed, and the D dimer spontaneously resolved, unlike in the pediatric age group. Otherwise, the 34-weeker went through well. 3 were asymptomatic, COVID positive, came for jaundice, didn't have. At that time, we had a protocol about screening all the babies who were coming from outbound for COVID, considering the epidemic nature which we were facing. One of them came with seizures, and the incident finding was he had COVID positive. And again, we don't know what was the culprit. Was COVID was an incidental finding or COVID caused the seizures? Same thing, one child came with severe hypernatremia, acute kidney injury, encephalopathy, sepsis. 2 children with RDS and requiring CPAP, one with low flow oxygen, other with sepsis. Fortunately, all the neonates got discharged. And the second wave, so far we saw 6 cases. Among the perinatal so far, I'm talking just from the April month. So we had 7 COVID positive mothers who are delivered so far, whereas 1 term baby was symptomatic and that was positive, and he's also asymptomatic. But what we saw was now is more of a later presentation, unlike this, where is, should I use a community transmission or transmission from like what Pradeep has shown is coming from mother and father to the newborn. So we had this 33-weeker IUGR who was doing sort of well, about to be discharged home. Both the parents turned out positive. Then they stayed back at home. Then the repeat swabs were negative. They waited for another 5 days and then they came back and then they wanted to take the child home. And then the child started having fever. Then child started being evaluated for fever. Of course, the urine culture showed, evidence of E. coli. We thought it's UTI. But because there was an evidence of, mother and father being positive, we thought let's send a CB night for this child. And that turned out to be positive. And then just today morning, we had one child who's 1 month old, where the grandparents were positive at home, and this child came with high-grade fever, and there's a patch in the lung. Inquiry, and the other interesting thing is from the other branches we had was one from the Vizag, and this is for pattern, which was a 28-weeker who was discharged home at 34 weeks, readmitted within a week's time with a fever. Not very distressed, but when you put a saturation on, the child was having a saturation of 85 to 86%. And the X-ray was showing a patch. And parents were saying the child is coughing. Similarly, in our other branch in Hyderabad, the LB Nagar, we had 2 children who were shown. One of the 30-weeker, again, doing well, planning for discharge. At the time of discharge, was noticed to be coughing. Did an X-ray, shown a patch. Parents were also turned out to be positive. And this child has an RT-PCR positive. And the other one was, this is interesting, and this is something for this is, and when we reviewed the literature, we found, this is a 35-weeker infant of diabetic mother. We were having persistent hypoglycemia, requiring very high dose of GI, glucose infusion rate, not settling down, requiring octreotide infusions, and large for gestation age. And then mother was coughing at the end of sort of 1 week, turned out to be RT-PCR positive, then did a RT-PCR on the baby is also positive, and then suddenly shows up abdominal distension. And then you do X-ray, it shows evidence of pneumatosis intestinalis. Now there's evidence of necrotizing enterocolitis, which could be managed conservatively. Now we don't know whether the neck is because of COVID or neck is because of this octreotide can also cause. But when you look at literature which came from Wuhan last year, they reported 3 cases of neck in children who had COVID, especially among the late preterm. Next slide, please. When you look at the literature from the pediatric, I thought, considering that the dual thing which I do, I thought it's worth. In the first wave, almost from April to December, we had 219 COVID positive children admitted with us. We had nearly 84 children with multisystem inflammatory syndrome in child admitted with us in our PICU, which we have managed, and we can share it whenever the discussion comes in. But this year, just from 1st April to 23rd April, we had 380 COVID positive pediatric cases diagnosed in our lab. The number of children who are turning positive is huge. This wave has a lot of children who are coming positive. We already have 2 children who had multisystem inflammatory syndrome who came positive. Yesterday night, I had a 14-year-old girl whose troponin levels were 81, who's on 2 inotrope, who's admitted. And the number of video consultation says the number of COVID positive cases who had in, because 90% of your video consultations are COVID positive. So I think we're seeing for a lot more sicker newborns, lot more community transmissions, children coming with fever or pneumonia, children coming with myocarditis, and maybe we might see more neonatal misc in this second wave, is what I feel. But yeah, I think there are some states which have seen earlier. Let us see the experience from them. Thank you.
Thank you, sir. And sir, you are rightly said, like even few of my colleagues, consultants, we have seen few babies in which whether they are COVID positive or antibodies are there, their gut motility is very slow. They have got feed intolerance, not full blown neck, but they are not tolerating feed at all. So this is something which is very specifically we are seen in few of these babies. Yes, Snehal, please.
Yes, thank you so much. There was a comment, Dr. Parag Dugli. He's also said that his unit has seen 3 children with NEC. So we'll discuss that a little later on in detail. Now, may I request Dr. Ashish Mehta to share his views and his experience. He is a fellow in neonatology from Australia. He is a visiting fellow at. Can I?
तेरी आवाज में कुछ गड़बड़ है. Something is wrong with your voice.
He is a visiting fellow at Sick Kids and Mount Sinai Hospital. Hello. Yeah, can you hear me?
Yes, yes.
Yes, he's a director at. Okay, guys, I think there's a problem with my.
No, I think Ashish needs to mute.
Yeah, he's a director at Arpan Newborn Care, director of NICU Sterling Hospitals, and a visiting faculty at the VS Hospital Medical College. Over to you, Ashish Mehta, sir.
So this is Baba mental ventilation. Sir. Sir. Sir, your voice unmute करिए sir.
मोहित सर, आपकी आवाज में भी आ रहा है प्रॉब्लम.
ऐसा है सिस्टम में कुछ है क्या?
हाँ, no, there is a problem with everybody's voice.
Yeah.
My God.
Yeah, I think it is a problem with all of them.
So we should stop that, allow participants to unmute themselves.
I don't think that the.
Hello.
हेलो. अभी ठीक है?
ये अभी ठीक है.
हाँ.
मेरा आवाज ठीक आ रहा है?
आ रहा, ठीक आ रहा है.
हाँ.
आशीष सर.
So, आशीष सर. आशीष सर.
आशीष मेहता सर.
We have to unmute him.
Yes. So.
Hello.
No, we will have to unmute.
Yeah.
बोलें सर.
No, again there is a problem. जैसा हम और किसी का आगे कर लेते हैं, नवीन जैन सर का कर लेते हैं, and then we'll let's see. Okay. May I request Dr. Naveen Jain to come? Yes. So Dr. Naveen Jain has given a very short introduction. He's a senior consultant at Kim's Health, Trivandrum. We have been hearing him for neonatal care since ages again. All of them are Galaxy speakers. So without much ado, Dr. Naveen, sir, please, your experience of neonatal COVID 2021.
This is Baba Blue Book Wale. Please, sir. Naveen, sir.
We have had a little less stormy wave one, where we only saw two really seriously sick COVID positive babies. These were outbound babies who were referred after being tested as COVID positive. In the beginning of COVID, 30 March last year, they were 33 weeks at birth and 1 month old. We transported these babies. It was a scary experience at that time, going for the first time in those white suits and getting these babies. They were ventilated for 2 days. One baby required oxygen for long. We treated them without using any of the steroids or remdesivir, and they got better. But subsequently, because it's a hospital which was admitting COVID positive pregnancies, and most other hospitals in the city were not, we have seen, can you show the next slide, please? We have seen over 100 positive mothers in the last 1 year, but all the babies were negative. We have very, very strict protocol of admitting pregnant mothers into a respiratory COVID area. And unless they are tested negative, they do not come into the common pool of the hospital. So all COVID positive, symptomatic, asymptomatic mothers go to a certain area, and then they are separated from the baby till such time that the family wants to take care of the baby with the mother with a volunteering bystander. So most of the mothers were separated from the baby after first few hours of colostrum feeding. They were able to give express breast milk if they chose to do so. All these babies were discharged asymptomatic and COVID negative from the hospital. During the same 1 year, we had maybe about 6 to 7 or more babies who were febrile, and like presented by Dinesh and Srini, they were tested because family members were also positive and they got admitted along with the family members. Kerala has been raging with COVID when most other states were silent in the last few months. In fact, you would require a test to get travel from Kerala anywhere. But we did not see sick newborns still in this wave. Back to you.
I think we will go to the next speaker.
Yes.
Yes, Dr. VC Manoj. He's one of the very few people who has done MSc in neonatology from Cardiff University, UK. He's also an FRCP-CH from UK. He is the head of Department of Neonatology, Jubilee Mission Medical College and Research Center, Thrissur. Sir, your experience from another one from Kerala.
So I would say, like, no, he is Baba of international speakers. He brings all international speakers to India. Thank you, sir. Please.
Thank you so much, Mohit and Snehal. Since we had a very grave view of what was happening, probably my views, I don't know how significant they are. Like, I was trying to do a verbal survey with all the centers that are doing tertiary care, because we are talking about sick neonates. And then I was trying to take out some data, and Kerala, as Naveen was saying, is yet to peak. And we are always late. Even the first wave, when everybody else was experiencing, we were not having it. And when everybody else, the first wave almost subsided, we started getting it. So like the second wave also, probably that is a scenario. So this is the total number of neonates. This is of both the waves together. The total number that I got, I don't know the accuracy of this. This is from from the centers whom I spoke to, which are taking care. So around 100 babies are positive. From a mother, from almost like 7,000 mothers who were positive. So the positivity of the babies, as Naveen was saying, is quite less. Now the sick babies, something interesting so far, or probably as the reason maybe the second baby is yet to peak, is that we have had very few cases of sick babies, and especially in Naveen is fortunate to be in the southern Kerala, where the numbers are even much less. So far I got report of only 3 sick cases in the southern Kerala, but in central Kerala, from Cochin upwards, central and north Kerala, there were 9 cases. And then I was trying to look at the typical ARDS feature was described, it could be convincingly described in 3 of these cases. And the MISC was in one case, which was reported actually from a 3-week neonate from Amrita Institute of Medical Sciences, Cochin, which was actually published in March in Lancet also. And but as was generally remarked by all others, the general morbidity and morbidity profile of the COVID positive babies is much higher. One of the babies even now is about to face, very bad in PPHN babies. There most of the preterm related, and like the systematic review that showed MISC has more GIT symptoms. The preterm related issue, mostly NEC, those issues are also there. So preterm related issues were there, pneumonia, a few TTN and 1 encephalitis. So this is the data I can say from the whole of this thing. Because my center, even though we are taking care of ours, the tertiary center, probably referral center for 3 districts of the state, probably our numbers are not much here, but this is the data which I can speak of. Thank you.
Yeah. Can we unmute? Thank you so much, Manoj sir. I think there was an issue with Dr. Ashish sir.
Now, if he has rejoined, I've told him to rejoin.
Yes. Can we have Dr. Ashish sir's experience?
Yeah, basically, as you can see that the first wave was quite, am I audible?
Yes, you're good to go, sir.
Yeah, basically, I must have personally attended more than my team, not me only. My team must have attended more than 50 deliveries, to be precise, 64 deliveries in the first wave where the mothers were positive. And out of this, only one baby had RT-PCR positive, which we normally do for all babies after 24 hours. And all mothers recovered, they went home and everything was fine. This wave is little different. Why so? Because this time so far we had 7 RT-PCR mother positive delivering a preterm babies. And out of this, of course, the babies, all babies were negative. 2 are preterm and still in the unit, and they are doing well, but they have that initial NEC kind of picture. But I can't attribute that to the COVID because they also had absent ductus flow in both the mothers, both the babies. So we can't attribute that to the COVID. Otherwise, they are doing well. Now, interestingly, we had 2 postnatal transmission, and this baby presented on day 5, which was transferred from another city. I can't say the postnatal also because day 3 baby become positive, baby is symptomatic. This mother had COVID and 7th month of pregnancy, and baby started behaving abnormally. No sign of sepsis as such, blood culture negative, but the markers were positive. And because mother had COVID positive during pregnancy, the referring consultant asked for the antibodies which are positive, strongly positive COVID antibodies in the newborn baby on day 3 of life. And all inflammatory markers include D-dimer, IL-6, BNB, everything was raised. This baby ultimately ended up with 2 ionotropes and improved, had signs of all myocarditis, very small Q complex on the ECG, and ultimately required IVIG. Baby immediately, I'm not saying immediately, but within 2 days of giving IVIG, baby improved. And we could win off the ionotropes and went home. Another baby came with 41 area of 45 of age, mother positive, grandfather positive, baby become positive, all signs of myocarditis, improved with IVIG. We were about to give prednisone on this baby, but luckily with IVIG, baby improved and went home. 2 babies that we are recently seen yesterday, high grade fever, diarrhea, both mother and father are positive. This baby's RT-PCR is these are again suspected COVID neonates. This is where we are. Now, out of all this thing, worry is that 2 mothers are on ventilator. I said 7 babies getting delivered, 2 are on ventilator. So, little bit grim situation here, but not as bad as what the Hyderabad or Dr. Chirla is reporting.
Thank you so much, sir. Now, may I request Dr. Mohit Sahani, sir, to share his experience? We have had a bad experience in Surat, Dr. Mohit, and that has led to this conference. Dr. Mohit.
Yes, thank you, Snehal. So as I am the moderator, so and this is the peak, the maximum thing to get off is, with the, all Babas is someone who can treat Corona. So I would say I'm Corona Bhagao Baba. So like as everybody told, like it was the same experience with us in when I would say the first wave, I would say is that COVID-19. There were very few newborns at that time, and those who presented, the average age of presentation at that time was first week. There was no vertical transmission, even though the mothers they were positive. Maximum cases the mother was positive, but they were very stable, asymptomatic, and they did not need any active treatment. And this wave, in last 2 weeks, I would say, like as it has been called as COVID-21, we have seen many newborns less than 1 month in outpatient and inpatient. In this particular thing, what we have seen is not only the mother, only 50% cases the mother is positive, but in other cases, other family members who are staying, they are positive. And the average age of presentation for this second wave was second to third week of life. Few of them, they were very sick, like 14 to 15 babies, they were very sick. And we had 4 mortalities in Surat, 2 in our unit, 1 in one unit, and 1 in Civil Hospital Medical College. In our unit, till now, we have seen eight babies who were very sick. 2 expired, 4 were ventilated, 1 was on high frequency nitric oxide. We treated 2 babies with remdesivir, 3 with IVIG, and methylprednisolone dexa in 5 babies. So this is our experience for this wave. So we will start with the questions with the panelist, and we will take few questions for Dr. Suryavanshi because he has to go somewhere. So I will start with Dr. Murki sir. Sir, any as you have your Indian Pediatrics publication, that was the data of the newborn with COVID. But everybody has gone through this. But I just want to bring up this for the stable babies. Any recent guidelines for the newborns who are born to the COVID positive mothers who are stable newborns? And what about the breastfeeding? You have already answered this, but just in short, if you can answer again, Dr. Murki.
I think so. Follow SMS, mask, social distancing, and hand hygiene. So breastfeeding should be promoted. I am seeing some people are reporting that they're seeing hyponatremic dehydration, infections, diarrheas. These are much more worrying things if you separate the baby from the mother. And I feel whatever NEC you are seeing is because of formula feeding or because of feeding with other issues and not with breastfeeding. So I think we cannot get away from breastfeeding, but continue breastfeeding in stable, healthy babies. But ask the mother to wear mask while she's breastfeeding, hand hygiene before and after, and ask the mother to keep the baby away from her by 2 feet. By 2 meters or 6 feet.
Great, sir. So as sir has told, and very recently, like our NNF IAP and our Gynecology Society, Obs and Gynecology Society, FOXY, they have come up with these guidelines, and I'm really proud to say that these are the best rated guidelines internationally. Thank you, sir. Thank you very much. The next question is for Dr. Pradeep Suryavanshi. Sir. Pradeep, sir. Suryavanshi, sir. Are you there?
May I request all the we have unmuted everyone, so the panelists will be able to unmute themselves and then speak.
Suryavanshi, sir. I think so. He must have. Okay. We'll take another. Let's see. I will take the question with Dr. Dinesh Kumar, sir. Dinesh, sir, are you there?
Yes.
Yes. So this is a question for you, sir. A 15-day-old term newborn who is born by normal vaginal delivery, who is stable and is with mother at home. Grandparents are tested positive for COVID. He presented on 15th day of life in your ER with a history of fever, respiratory distress, and saturation 70%. So what investigations you will do in this sick newborn related to COVID? Like all normal we will do, but what else we will do in addition, sir?
Yeah. So I think from the chat box, I'm seeing that a lot of people are seeing many babies with COVID. That's what I can realize from chat box, especially from maybe some part of the countries. So obviously, as it's considering that the child had exposure to grandparents from being COVID and coming with a strong history of fever, respiratory distress, you suspect this is a neonatal COVID. So as Mohit has said, you'll definitely, one thing you have to remember, any newborn presenting, you have to rule out sepsis and pneumonia and regular causes you have to look for. Please do not just say that this child doesn't have. So you do your routine blood cultures, CBP, CRP, those things are taken for granted that you're doing. Get a chest X-ray done, start your line of antibiotics for coming with sort of, late onset sepsis. But specifically for COVID, this child will definitely get an RT-PCR done. Now, what happens is here two things. How many of units will have the, where do you keep these babies is one of the biggest query a lot of, units have. You have facilities about where do you keep them in the unit. So RT-PCR is available. What is the turnaround time? Or do you want to do CBNAT? If it's available, it is going to come quickly. That is one thing, which is very specifically done. Now, when you have a respiratory distress with fever and oxygen saturation low, two things possible. Is it primarily because of a lung problem? Or second, what we are seeing is a lot of children coming with myocardial involvement who also might present very similarly. So this is the second thing which we have to think. So if your RT-PCR is coming positive, or if your clinical examination suggests you of sort of more of cardiac involvement, or ABG showing evidence of severe acidosis, that's when things like getting a pro-BNP troponin level, getting your ferritin, interleukin-6, and D-dimer levels, specifically which we are doing in children who are presenting with neonatal COVID are to be done. But I would say your first line, definitely for someone who's coming to your ER, would be getting your ABGs, your chest X-rays, your blood culture, your CBP, CRP, get it done. Send for COVID. Take all precautions when you're managing these babies. And based on your clinical markers, get your specific markers like your troponin, pro-BNP, IL-6, ferritin levels.
Thank you, sir. So Dr. Suryavanshi had to leave had to go somewhere. I will just point out, take out his questions, and then I will just, that how the sick COVID positive newborns presented in his, like he has already told in his introduction, and everybody must have discussed. Most commonly, these babies are coming with pneumonia, respiratory distress, fever, dehydration, hypernatremia, and in shock. This is commonly also we have seen the sick babies who have died. They are presented with this presentation only. So it was very common presentation in these babies, especially in this wave. And then regarding the management, he has already been summarized initially when he showed his slide that mainly he has used paracetamol and steroids. And regarding IVIG, we will discuss regarding remdesivir and tocilizumab, everything we will discuss. But mainly what he has shown in his slides is that they have managed with paracetamol, IV fluids, and with steroids, and that to methylprednisolone. So I wanted to ask specifically this question to him, Dr. Suryavanshi, that any specific echo findings in sick newborns that are COVID positive or suspected neonatal MIS-C? Because there are a lot of data which is coming out regarding the echo of adult patients and regarding the pediatric MIS-C patients. But newborn, well, nothing specific was there. But this is what I would just show this table, if you are able to see, that this is what we have found in sick babies, our 8 to 10 babies we have seen. And this is what their structure was normal. And we try to correlate the prognosis along with this. The most common thing what we found with babies who are very sick and with poor prognosis was their RV-LV dysfunction. When we calculated their RV functions by TAPSE, it was just 3 to 5. Normal in term babies is more than 6. It is mostly 6 to 10. And LV, we did fraction shortening. Normal is more than 25%. For these sick babies and those has expired, they had 5 to 10% of LV functions only. There was mild pericardial infusion in 3 to 4 babies. And what we saw was when we did the VTI for the pulmonary artery Dopplers, it is less than 4. And that also correlated with the poor outcomes. LVO, left ventricle output was low normal, was not very bad. And when we saw as these babies were very dehydrated, their IVC was collapsing. It was collapsed. So that also had, they also had a poor outcome. And as from the data of the pediatric, we did check for the coronary artery sizes. Only one baby who died had a dilated coronary artery. Rest the sizes were normal for their Z score, but the VTI was normal in all these babies. So it was not relevant. So we could only see that dilated coronary artery baby had a bad outcome. So this was our echo correlation with the prognosis and treatment of this baby, of these babies, what we got.
Can I say something, Manoj, rest regarding? See, when you are suspecting, I think, I could see from the chat box a lot of others talking about they have experience in MISC newborns. And I share some neonatal MISC and also a lot of children who managing MISC, close to more than 84 children. Is once you see, because one of the commonest findings is poor cardiac function. And also one of the things you can show is elevated pro-BNP and troponin levels, which you'll find out. And the blood pressure could be very low and they come in shock. Dilated coronaries may or may not be present, and especially in newborns we don't see. And this is something which you found in children also. And the way to get around is strike them hard, because this is all what you're seeing is an inflammatory reaction. So strike them hard with steroids. That is something which we have to see. If you are finding a child like that, strike them hard with steroids and IV immunoglobulin, and they do turn around. I had a pediatric child who almost were landing up with ECMO with 4 inotropes. And we had to give them pulse dose of steroids, and they turned around in next 24 hours, and we were gradually able to wean down. Similar experience has come from adult side also, when they found a cytokine storm. I think from children, newborns, if you start seeing many with MISC-like feature, which I suspect usually comes 1 to 2 months after when you start seeing the peak of COVID. In newborns, especially in children, newborns will have to see what it will see. Maybe it's worth for us to look at the inflammatory markers, look at the cardiac markers, and strike them hard. Anyone else can also, but whatever has been come in the Lancet, there have been 1 case report, and that too has come from India only. And their experience also has been to strike them with steroids and immunoglobulin.
Can I make a comment regarding that, Mohit?
Yes, please.
It was regarding the same case which you had mentioned. It was actually, like the baby was referred to the hospital for cardiac evaluation. They did not suspect it. It's an outbound baby that was referred to this center for cardiac evaluation. So baby was very sick, and they found that they did an echo from the peripheral center. They found that the baby is in failure, and they referred. They had not suspected COVID at that point, because this was during the time when Kerala had not started seeing. Even now, I don't know. Some areas have not started seeing sick babies. So the suspicion of COVID and all this MISC and all came much later, but because they ruled out everything cardiac, then they found that the D-dimer, the BNP, everything was raised, and then the whole turned around actually.
Yeah. Thank you, sir.
Yeah.
Dr. Mohit, may I intervene?
I
May I intervene,
fully
Dr.
agree with
Mohit?
Dinesh. I fully agree with Dinesh because
Sir, actually, we will discuss the things in later, because we have to finish off the questions. Yes, cardiac things are been there.
One comment on the cardiac, Mohit.
Yes, sir.
Our cardiologist who sees a lot of newborns, he says that if there are evidence of MR and AR, if mother is COVID positive in the pregnancy. So we are hearing other malformations, but our cardiologists who have seen that MR and AR are associated with neonatal MR, AR are getting associated with maternal COVID. I don't know, maybe you can keep looking at this and maybe you will find some association.
Sure. Yes, sir. Thank you. Okay. So Dr. Naveen Jain, sir, are you there?
Yeah.
Yes, sir. So if the mother is COVID positive and sick and she is admitted in an ICU herself, but the baby is stable and term, so how to manage this baby and where to manage? How to manage the feeding of this baby, sir?
See, most of the mothers we had in the first wave were not sick. Mothers also were not sick. Almost 100 mothers who were COVID positive, and none of them required oxygen or ventilation during the first wave. Mothers also. And the first few hours after birth, the mother and baby stayed together in the same COVID ward, which was meant for mother and baby alone. But unfortunately, after the first few hours, what happens is this COVID ward has to be vacated. So mother goes to a common COVID floor. We had 3 floors.
Sir, unmute कर लीजिए sir अपने आप को unmute sir unmute.
So sorry, we had almost 100 COVID positive pregnancies, but none of the mothers required oxygen or ventilation. They were not sick during this period. So I can share experience of managing where the mothers were not sick. In this case, the first few hours, mother and baby stayed together with mother using a mask. And after breastfeeding, she was putting the baby a few meters away in a bassinet. But because the mother had to be shifted to a COVID ward where there were not other family members to support, sometimes the baby had to be separated with the COVID negative family members into a room. Sometimes express breast milk was made available. Sometimes logistics didn't allow some member to carry the breast milk each time, or a hospital staff to go to the COVID ward, get breast milk each time and get it to the baby. But after discharge on third or fourth day, the mother was going on home quarantine. The mothers were allowed to breastfeed the baby with mask at home. And we have not had a single sick newborn baby getting positive because he was allowed to breastfeed directly with a mask in this period. So I would suggest that if there is a family member, out of this 110 cases at least were there when the husband volunteered that I'm willing to take the risk of getting COVID, or a grandmother volunteered and stayed with the mother and baby in the COVID ward, they were able to breastfeed through and through without causing any risk to the baby. So the bottom line is that if the mother is willing to wear a mask and breastfeed the baby, there is no contraindication, is what we learned in the last 1 year.
Thank you, sir. Thank you very much. So the next question is for Dr. Ashish Mehta. Ashish Mehta, sir, are you there?
Yes, I'm there.
Yes, sir. So if mother is COVID positive and sick, admitted in ICU, as we have created this scenario, but baby is stable and term, but there is no one, like as per sir, the husband and grandmothers were, but there is no one to take care of this baby. And this baby had to be admitted for observation and feeding issues because there is no one to look after. So then the issue is now where to admit these babies. There are two type of babies. One who are born to COVID positive mother and their test is results are still awaiting. And one, the babies who are COVID positive by themselves. And other are non-COVID babies born to non-COVID mothers. So how to segregate these babies in ICU?
So basically, nice to know that about Naveen's statement. The reality is that with RT-PCR positive mother, newborn, we are supposed to keep baby with mother. That has been discussed right from beginning. There is no need to isolate these babies. Baby can be breastfed. The reality is that in the COVID ward where the mother has delivered this baby, no relatives are allowed. And there is always a shortage of the staff. Because of that, the babies are being separated, plus there is a panic reaction among the relatives that we do not want to keep this baby among the COVID positive patients. And that is why these babies are isolated into the NICUs. As far as public or government hospitals are concerned, they are in the COVID positive, COVID NICUs. As far as private sector is concerned, we have isolated area where these babies are kept if required admission. As I told you that because the panic reaction, this baby come to NICU. Others, ideally, this baby should stay with mother. Now, after admission, at 24 hours, RT-PCR has been done. And if it is studying negative, they are discharged with the advice for the cutlery spoon feeding. And once mother is discharged from the public hospital, mother starts breastfeeding these babies, and all of them have done well. Those coming positive, pneumonia, postnatal transmission, and those coming positive, they stay in the different area of the hospital where there's a total isolation and they are separated from the normal babies.
Thank you, sir. This is very important because those who are positive need to get separated in separate ICU for them. You have to create separate ICU for them. And those who are suspected should be in some transition zone, should not be in with the normal babies and should not be with these babies. Dr. Manoj sir. Dr. Manoj, are you there?
Unmute.
Dr. Manoj sir?
Yeah, and sorry.
Yes.
Can you hear me?
Yes.
Yeah.
So, sir, now I just want to ask, like, the question is, if the mother she is on remdesivir or on tocilizumab, and she is stable, can we give breastfeeding or express milk to the newborn? And which are the drugs related to corona which are being given to the mother? They are contraindicated in breastfeeding, sir.
So things are going a bit in circles regarding this. Breastfeeding guidelines, if you look at, as was rightly mentioned, the COVID guidelines, ours is one of the best rated guidelines for COVID management. Breastfeeding, if you are really going to look at all the guidelines available, you can find there are three types of guidelines: the most conservative and the most liberal and something in between. The WHO guidelines is the most liberal and probably the one that majority of us all stick to, where breastfeeding is permitted in all scenarios with very rare exceptions. The conservative one, the Chinese guidelines still remains almost same. The middle path, the American guidelines have almost come to the WHO guidelines. So breastfeeding as far as possible should be done. There is no risk of transmission because of breastfeeding. That has been reiterated by everybody. Now, the specific question regarding the remdesivir and tocilizumab. So, remdesivir, no information is available on the use during the breastfeeding. But we know certain things. Babies are not likely to absorb. We know that remdesivir is given IV, and IV medications. Why is it given IV in mothers? Because the oral absorption is very, very poor. So babies are not likely to absorb clinically important amounts of drug from the milk. So probably, and then we have some other data. On the other side, we have data from the Ebola epidemic, where newborns were treated with this drug, remdesivir, and then they had no serious adverse reactions. So the adverse reactions reported were some elevated aminotransferase, bilirubin levels, other liver enzymes, diarrhea, rash, and all. Very few, and even the renal impairment, hypotension, that was all reported were all very, very minimal. So like it is safe to breastfeed the babies even if the mother is getting remdesivir. But of course, we know that it's unknown territory. So until more data is available, the drug should be, now that the use is slowly being questioned, although some of the authorities don't agree. So like some people say there is no use in giving also. So like it should be used with caution. But if you are decided to give to the mother, do not stop from breastfeeding. Now regarding the second part, that is that's regarding tocilizumab. We have some information available. This is mainly from the Japanese data, the mothers who were treated for rheumatoid arthritis, Still's disease, etc. So only very little amounts of this drug was detected in breast milk after IV dose. So this is probably because it may be partially destroyed in the infant's GAT and absorption is minimal. So if mother requires the drug, give it. And until more data is available, as I said, it has to be, you use it with caution. It's actually a human IgG G1 kappa antibody. So probably you can use it.
Thank you, sir. So one of my colleague, like he is in practicing very nicely, has made this pamphlet. And to just help for, as you told, in remdesivir, it is safe, but still the data is not very clear. Tocilizumab, still the data is not very clear. So that's why we say it is cautious, like similar for ivermectin. The only thing which you should avoid the breastfeeding or EBM is doxycycline and favipiravir. These are the only two drugs. Otherwise, most of the drugs you can give, as you have rightly said. So this is for Dr. Murki.
Exactly.
Murki, sir.
And if there is a
yes, sir. Please.
Okay. I just want to, if there is a confusion for the audience, if there is a confusion whether to use or not, the authority you can use is the database from the LactMed, Drugs and Lactation Database. with again US government database. You put the drug and then you will get all the data. It's very easy now. So, but maybe you may find some difficulty because the extracting the other details regarding the disease may be difficult.
You can write that in your in the chat box so that everybody can see, sir. Thank you.
I will do that.
Please, sir. So, Murki, sir.
So I don't know whether I think people are gradually falling off from remdesivir and tocilizumab. If you look at the recent guideline from AIMS, which is got published on 22nd, remdesivir has become an optional drug because it only decreases the duration of hospitalization, and it should be given in the first 10 days of illness. So when you are having the persistent fever for more than 5 days, oxygen dependency, moderate to severe cases, you end up giving remdesivir. But if it's given within the first 10 days of illness, it has a value in decreasing the duration of hospitalization in children or in adults. But I'm not sure of any role in newborns because obviously we are going to extrapolate everything in newborns. So I think of children and think of adults, how they are managing. Maybe we can extrapolate the similar findings to newborns. Now, tocilizumab is another similar drug which is used only for sick adults. And again, it has a questionable value and not many studies to prove that it is a wonder drug or a needed drug. So I would suggest that these drugs are used only when indicated and under the guidance of experienced people. At least take the opinion of people who have used this drug so that you're sure when before starting using this, you're sure what conditions you should never use it.
Thank you, sir. Dinesh, sir. Dr. Dinesh, are you there?
Yeah.
Sir, this is any role of IVIG and or steroids in the treatment of these sick newborns? And if steroids is yes, then which steroids you would prefer, sir?
As I mentioned briefly in the earlier, definitely whenever you see a marked inflammatory reaction, especially you're suspecting MESC, myocarditis, increased inflammatory markers, that's when probably where you have a role of IVIG. Primarily, I would say COVID and myocardial involvement. You have a child presenting with neonatal COVID with shock. I would probably definitely poor cardiac functions. You have features like you have a MR or TR having ejection fraction is low. Your troponin, pro BNP levels are high. He is a candidate for IVIG. You may not find dilated coronaries in the newborns. And definitely some of the children with the high inflammatory markers who are very sick, they would be probably candidates for IVIG. As far as steroids are concerned, yes, whenever you have high inflammatory markers, high ferritin, high interleukin 6, especially into sort of the second, those who are presenting later, not in the during acute viremia phase. It holds very true like the way it holds in children. That is when we would consider steroid. That's what has been our experience about whatever few neonates we have managed with neonatal COVID and steroids. And steroids in the children population also. What steroids? I don't think there is a clear guidelines in newborn that methylprednisolone is preferred over dexamethasone. A lot of neonates are comfortable with dexamethasone. They're comfortable with dosing of dexamethasone, and that is the reason why when I actually reviewed some of the cases who have used methylprednisolone, they have used 5 milligram per kg followed by 2.5 milligram per kg. So yes, any one of the steroids can be used. But if you ask me, is there a definitive guidelines, but which one is there? I don't think there is a definitive, as at this stage, evidence-based recommendation which I can give. Go by the steroids which you prefer. But if you look from the pediatric literature or if you look from the adult literature, people go more by methylprednisolone, and we probably need a little bit more evidence from the units where we start using methylprednisolone. Now, coming to sort of the earlier things, and I looked at what has, because remdesivir, as you know, is licensed for 12 years onwards. I tried to look what has been looked in children. 3.5 kg and above is when you have, it said you take permission and start using it. So essentially in newborn, it essentially not licensed at all. But there have been some case reports of people using remdesivir, but nothing much. I saw that Mohit has used in a couple of his cases remdesivir, but I really do not know um, how it will be, where we should really, and it is, I think when you really have a very sick one, you're pushed to the wall, you have nothing to lose. Probably that's when people are using it. Not much data has come up, published data about remdesivir in newborns.
Yes, sir. And I would discuss that case also in short, but the two babies we have used, personally, our team has found there is no use of remdesivir in those babies. It did work
Yeah,
well.
Mohit. But recently in the pediatric infectious disease journal March 2021, they have reported two cases where the baby were very sick, stuck on a ventilator, and ultimately they used remdesivir and improved. But this is just two report from the US nursery
Yes.
on use of remdesivir in newborn baby. Pediatric infectious disease journal March 2021 issue.
Sir, our baby, we gave
Yeah.
10 days of remdesivir and was still positive after that. We had to, and the other baby became more sick after completing the course of remdesivir. I will show you that even the X-rays also of that baby. Okay,
And
fine.
they use it early. In the case
Yeah, early. We have
Ashish
started on the
was
day
saying,
one of admission.
they
We have
used it
started on
early.
that. We also
Ashish,
used early, sir.
Yes, they used no, they were using on the second week after fifth day.
Yeah.
Because by that time they are access everything, they give surfactant, use antibiotics, but babies are really sick and then inflammatory markers are increasing. Baby had low grade fever also. For that matter, they used it. I'll send you the references.
Yes, sure. Thank you, sir. So this is the next. Dr. Manoj, are you there?
Yeah.
Dr. Manoj, yes, sir. So this is 21 days old term, male newborn, presented to your emergency gasping in shock with a history of decreased oral intake and low urine output the last 1 day. Mother was diagnosed COVID positive 5 days back. Sir, this is again, Dr. Chirla has already told, but in specific, I just want to ask, is there any role of significance of D-dimers, pro-BNP and echo in these sick infants who present like this, in very bad shape, who present? So because in
Okay.
a couple of our babies who expired, I have seen like their pro BNPs were more than 30,000. I've never seen such value in any newborn. I've seen till 10,000, but more than 30,000. So.
Okay. So D-dimer, we know, is a fibrin degradation product. It's often used to measure and assess clot formation and all that. And it's usually elevated in patients with COVID-19. Elevated D-dimer is associated with disease severity and mortality trend in adults. This has been proven. And some people say value more than 1 microgram per liter is one of the risk factors for mortality in adult patients with COVID-19 at all. About children, do we have evidence? I was trying to look at the literature. The most impressive one is the Spanish data published in last year, September 2020, after Spain was one of the worst hit with the first wave. So they had studied 309 children, but the age group, they included newborns also, but they were babies, children up to 15 years. So initially it was normal, and then it shot up, and the higher levels were associated with more severity and of the disease and mortality. So probably there is some role for this, especially when you combine it with, as you rightly said, the natriuretic peptides, because these natriuretic peptides are biomarkers of myocardial stress. And they are usually we all know it's elevated in respiratory illness, but they may be elevated even before the filling pressures and the get elevated and the clinical heart failure sets in. So early detection, you can use levels of BNP, pro BNP, etc. And in adults again, these like troponin, again BNP, pro BNP, etc. they are associated with unfavorable course in these patients with ARDS. Now, regarding whether you should use it as a routine practice, because the cardiac, there is a guideline which interestingly said clinicians are not advised to measure troponin unless you suspect acute MI. So probably we can use it along with other parameters to assess the severity of COVID once you have its COVID setting. And echo again.
त्याला देत होते तर ओढलं जोरात सगळं सांडलं माझ्या अंगावरती त्याला दम हे घेता येत नाही अरे मला चहा पिताना पण मला त्रास
Okay, so again, the all the three parameters can be used in this baby. There is definitely a role. How useful are they? Whether how sensitive, sensitivity, all these things we don't know. But definitely in a scenario like this, when you're facing a really sick baby, as a baby that you described, definitely I would go in for all this. And echo will be definitely useful. Almost all the patients who are sick, the sick babies, they all had echo findings. So probably that is also useful.
Thank you. So this is to Naveen sir. Naveen sir. Sir, this is like like as Dr. Manoj has told, like they do have the role, but does these things steer your treatment? If yes, then how and when to repeat these investigations if they are deranged initially?
I have to be honest that I have not done these tests myself in newborns, but my wife is a pediatric intensivist and they are seeing pediatric MISCs. And I get a lot of questions from friends who landed up testing these at the request of parents in well newborns. So please remember that in well newborns or newborns who are exposed to COVID positive families, there is no role for these tests. They are only useful when their newborn is sick. This is a single message I can give with confidence to the group, that if a newborn is non-sick and not in clinical DIC, please do not do this test. Many of these tests will have different excretion times or metabolism times. So just like we talk about lactate, I'm not sure that the D-dimer or rising and falling can be very accurately predicting the response to your treatment or progress of disease. It has to be mostly clinical. This is only common sense. I have no personal experience.
Sure, sir.
I agree. I mean, in early day, when you had COVID and we didn't know what to do, a lot of newborn used to get very raised D dimers, but the child is to be, and you really, treat the child. Don't do the test. That's probably the
I think well child should not have a test done.
Don't do that.
We used to do pro BNP 10 years back when we did not have immediate access to echo in the NICU, and those with PDA started getting very high pro BNP for everyone. Then we did a few pro BNPs for non-PDA babies, and it was high there also. So please remember that many of these tests have very wide range. To try and search for today's meeting, they have tried for HFMD, hand-foot mouth disease also they have used pro BNP and D-dimer. And for sepsis also there is a paper from India from D-dimer, which has shown very low specificity. So negative predictive value is very high. So if you have a sick newborn and you do these values and they are negative, then possibly this baby will not go into DIC or progressive illness. But even a well baby, no value. In a sick baby also, presence of these values does not mean that they will surely die or they will become very sick. I don't think it can guide therapies. It has to be based on clinical hemodynamics and respiratory parameters. This is what I feel.
Sure. Thank you, sir. Ashish Mehta, sir.
Yeah.
Ashish, sir. Sir, hello.
Yes.
Hanji, sir. Sir, if RT-PCR is positive on day, hello, sir. So the question is, if the RT-PCR is positive on day 1 of admission of this newborn, and now the baby is with you for the last 10 to 11 days, when to repeat the next RT-PCR if it is positive on the first instance? And is it compulsory that baby should be RT-PCR negative before discharge? It becomes well.
Not required. No need to test this RT-PCR again, as we know that even the dead virus also bring this test positive. So there is no need to repeat RT-PCR. What is required is after 14 days, this baby can be roaming in with as a normal baby.
Okay, sir. Sure. Thank you, sir.
Even that is true for any adult these days. There is no need to repeat RT-PCR.
Sure, sir. Dr. Murki, sir. Murki, sir, are you there, sir?
Yeah.
Yes, sir. So this
if you're symptom, I think the only message I could add is if the baby is symptomatic, then you may have to repeat. Sometimes your first test might be negative, but if you're symptomatic, some of the babies you may have to repeat. is what is the message that I would like
Yeah,
to.
that can be a sampling error. You are right, Dr. Dinesh. That may be sampling error, and because of that, at times your RT-PCR will be initially negative.
Yeah.
But when it's positive and baby is otherwise fine, 11th day of life, there is no need to repeat that.
Yeah.
Yep.
Okay. Thank you, sir. Murki, sir.
Yeah.
Yes, sir. So this is 22 days old female infant presents with shock with a history of mother COVID positive 1 month prior to the delivery. The infant, when he came admitted, is RT-PCR negative, but COVID antibodies of the mother, they are reactive, they are high. So can it be a neonatal MSC, sir? MISC, neonatal MSC.
Yeah, I think, but always keep in mind that this baby, you have to think of the common things first. It can be still a sepsis, can be still a dehydration or other things, rule out a cardiac cause. Then obviously, since there is an underlying risk factor, then you can think of neonatal miss. So in this child, if COVID antibodies of the babies are positive, and if the shock is there, and if you can rule out an infection, then you can say that it's a neonatal miss.
Thank you, sir. Dinesh, sir.
Yeah.
Sir, are there any specific guide how you diagnose a neonatal miss?
As I said, see, it's a new entity as when it comes to neonatal. The guidelines are something which we have taken up from the children which we have so far. And I think we have extensively discussed here about when to give IVIG, when to give steroids, these things. The only controversy in neonatal, this is about heparin, is what is one controversy in neonatal, which we hardly have used heparin. Majority of the cases, because the prothrombotic which we see in adults is not seen so much in children, and especially in the newborn, and the risk of bleed is there. Unless you have really very raising. I think I've seen, I don't know, Pradeep is there, because I saw Pradeep saying that he used enoxaparin in some of the children. So we really have to see, unless you have a documented thrombosis or you have a really rising D dimers and something, but if you say, if you have a specific guidelines, no, but you have two types of presentations. One is someone presenting with shock, with MISC. That is one of the presentation, and they are the one who present with, definitely do respond well with inotropic support, IVIG, and steroids.
Thank you, sir. Dr. Manoj. Manoj, sir, are you there?
Yeah, sorry. Yeah.
Yeah. So, like again, are there any guide or anything which guide us to how to treat this neonatal miss?
Again, it is like there is no specific guideline available as it. We have to interpret from whatever guidelines are available. So treatment ways, we all know the two key things, IVIG and steroids, and then probably interleukin-1 receptor antagonists also are there in all the guidelines. But whether to, I mean, like to confirm this, and rightly now there is a post in a chat box that it should be Miss NB, not MISC, because it is newborn, not child. But actually, if it is the specific, if you look at the epidemiological definition, it is occurring in children 2 to 6 weeks after the exposure. By then they would have completed the newborn. So I don't know whether, like with this terminology is the same, or whether we need to be talking about something else. So probably there is a systematic review published last year in Pediatric Respiratory Reviews, which has outlined the guidelines, and then they have just said that probably these are the key ones: the steroids, IVIG, and interleukin-1 receptor antagonists. And severe symptoms they reported were all the most common symptom all the babies had was GI symptoms, which was again mentioned as NEZ or whatever, motility problems or whatever, which was the same was some of our experience also in the severe disease. So guideline, I am not aware of any specific newborn treatment guideline for Miss NB.
Sure. Thank you, sir. So Naveen, sir. Dr. Naveen, sir. Naveen, sir, are you there?
Yeah, very much.
Yes, sir. Sir, any long-term effects on these newborns once they are COVID positive and they are sick on their development and anything?
I confess that we have seen only 2 sick babies who got ventilated in last March, but the advantage is that now they're 1 year old. Both these babies did not have persistent respiratory symptoms or signs like we see in adults. And neurologically also both these babies are doing well. So experiences from very limited number of 2 babies who are sick and ventilated. They were preterm, but they don't have persistent respiratory signs or neurological findings. Maybe I can hear from other colleagues who have seen sicker newborns.
Okay, sir. Great. Ashish, sir. Ashish, sir.
Yes.
Yes, sir. Sir, like once
Hello.
these babies are, Hanji, sir, if once these babies get discharged, then how to follow up these babies and what about their vaccination? Is there any change from the routine?
Don't know anything about. We are yet to start follow up these babies. Those who are discharged, they are doing well. But I do not have a fixed plan or protocol at this stage, which has come up in any journals or any literature. They should be receiving regular vaccination. Of course, very few newborn get steroids or IVIG. So the protocol for those who receiving IVIG and steroid will remain same like any other baby. But otherwise, all those who are otherwise have done well, they should be normally vaccinated.
Okay, sir. Great. So thank you, everyone. Like I just from the for the comments of the panelists and just for the information, this case is very interesting and behave like few of the very rare adult patients. This baby is a term large for gestation age male baby. Birth weight was 4.2 kg. Was at home after birth with mother. Mother was COVID positive on day 13th of life of the baby, and then baby was asymptomatic when tested. Was on day 14th was COVID positive. So first, this baby was admitted on day 15th with some feeding issues and SpO2 was low. Started on oxygen prongs, X-ray test was done, which was normal. We repeated again on fourth day. This baby was fine on room air, RT-PCR. RT-PCR was positive. But as baby was stable, we discharged the baby on room air with the mother. Then on day 23rd, after 1 week of admission, this baby again presented to us with fever and decreased oral intake and tachypnea. We started with the oxygen. Still, the baby was RT-PCR positive till then. X-ray test was done. This time, the X-ray was showing pneumonia. Right side, the whole pneumonia was there. And then this baby, after 5th day of admission, started developing bulle in the lungs. And then it had developed pneumothorax. So we had to put drain twice. We had to remove the air, like pneumothorax was drained with chest drain and ventilated the baby for 5 days. So this baby had bulle, and this has been reported in few of the adults. And this baby was showing that. For this baby, we gave remdesivir. After 6 days of remdesivir, this baby developed bulle and pneumothorax. Baby became sick. IVIG doses were given. Methylpred nothing was given. We ventilated this baby. D-dimers were always normal. CRP was increased. Max value was 300. And echo, when we did initially, LV and RV dysfunction was there. So this baby is still with us on oxygen prongs on 41st day. And interestingly, what we noticed was this pro BNP. On admission, when the baby presented, pro BNP was 3191. Normal value at that day of life is 500 to 1000 for these babies at that day of life. When baby became sick with bulle and pneumothorax, it went up to 10,000. And then the baby became better, it again came down. So the pro BNP was also going up and down as per the condition of the baby. So what I would say is, if your COVID babies are COVID positive, either they are COVID RT-PCR negative or positive. If they are negative and antibody is positive, as we have discussed, just for synopsis, that they are presenting with shock, pneumonia, multi-organ failure, or with fever and loose stools. Regular investigations, as we have discussed. In addition to that, we do D-dimers, IL-6, pro-BNP, LDH, and echo. Remdesivir, the treatment, nobody is sure, and our experience is not very great with this. IVIG on the basis of IL-6, pro-BNP, and echo is a good this thing, and steroids, most of the people are using, and their outcomes in sick babies are seen good. So I would say the things to note, as we have discussed, and we will discuss in the end, that if the baby mother is COVID positive, we should encourage breastfeeding. We should not stop breastfeeding. Separate room in NICU, as we discussed. Most common presentation in second wave is shock, loose stools, respiratory distress, and fever. Steroid, methylprednisolone, there is no data for that. We have just using it as what they have used in pediatric patients. And role of IVIG and remdesivir is still doubtful. In echo, as we have shown, as we have seen, RV-LV dysfunction, collapsing IVC, and dilated coronary arteries, they are related to poor prognosis, but still the data is very limited in very few number of babies. And as we have discussed that pro-BNPs and all inflammatory markers, they can, if they are sick babies, they can indicate for the use of steroids and IVIG. As my friends, we are all naive with all these treatment. So this happens to the same if you're first timer on the airport. We have a bag full of all type of injections, IVIG, remdesivir, everything, but we don't know the exact path. If somebody instructs you for something, you just follow that path, and this is how you end up with. So this is still our condition with COVID. Thank you very much. And now we will take the questions. So of all the people who are there, and our panelists are there to answer that. Snehal, please, we will do the question answer session for next few minutes, 10-15 minutes. Carry on with this, please. Snehal? Snehal, are you there? I don't know if it's not there. So we can start with the question. Okay. So Snehal, unmute. Question. Please ask the question to the panelist.
Let me check. Chat. Where is the chat? I am not getting chat. Okay. Vardhan, can you go ahead? I'm a little... Vardhan?
Okay, I will ask the question then.
Hello.
Vardhan?
Yes.
Yes.
So one question is, what about the bedding in of the babies who are negative but born to positive moms after breastfeeding? Is there need to separate at 2 meters distance after breastfeeding? Murki sir, if you can answer this question, please.
I would still suggest. I would still suggest avoiding bedding in.
So somebody has written Fabiflu contraindicated in lactating mother. Yes, it was a contraindication. Fabiflu was contraindicated.
Sir, Murki sir, the problem is that if we avoid bedding in, then the patient, the baby stays with the grandparents, and then the grandparents get infected. So that is that issue.
So
Dr. Murki sir?
Babies do not infect the adults. Asymptomatic newborn babies do not affect the adults.
So do we tell everyone that the baby has to be remain with the grandparents, and only every 2.5 or 3 hours, whenever the baby demands feeding, the baby comes to the mother. Mother takes due precautions, feeds, and then goes back to the other people.
Yeah. And during the time of feeding, mother holds the baby.
Yes.
And the attendant stays away.
Yes.
Please mute.
Okay. So one question is, sir, do anyone have...
Sir, you need to mute yourself. Unmute yourself. I have muted everyone.
Okay. So one question is, do anyone have any data on information on COVID vaccination in pregnancy? Can we give mRNA vaccine after 13 weeks of pregnancy? Is there any data with Covishield or Covaxin in pregnancy or lactation? Or any positive effects or complication in women receiving vaccine in pregnancy in USA and other countries using mRNA vaccine? I don't know who wants to give the answer to this.
Data is inadequate, insufficient.
Yes.
So,
as far as
sir,
the pregnancy vaccine is concerned, there is no data yet. So as such, it is not to be advised during pregnancy, that too in the early part of the pregnancy, vaccination part. As far as the breastfeeding is concerned, yes, vaccination can be given. We do not have Indian guidelines. American Society of Obstetrics and Gynecology, on their website, they have put that lactating mother can be vaccinated. And there is enough literature on that also.
Sir, so may I, to the panelists, so may I reiterate, Indian guidelines, Indian recommendations are not to give vaccine while breastfeeding.
No, there is no recommendation. There is no recommendation yet from Indian side.
Sir, when at our center, when we were giving, the government had come to give vaccination, they were denying vaccination to the breastfeeding mothers. So can we very categorically tell everyone that although the government has said no, you can take vaccine when you are breastfeeding?
Yes, sir.
Yes.
100%. But as I told you, that government guidelines have not come up yet. So they may not change their stand as far as vaccinating breastfeeding mothers are concerned. But as far as evidence is concerned, yes, you can do that.
Again, another question.
Yes, Dinesh want to say something.
Yes, sir.
I think to put it right, if you look at the vaccine manufacturer, it doesn't say it for pregnant and lactating mother. But recently, as Ashish has said, there is a lot of evidence has come up that it is fine to give to lactating mother, and that is the reason why we can safely tell the parents. But as rightly put in by someone in the chat box, you need a 1:1 counseling to the mother. You said there have some literature come up which is saying that it is safe to give to lactating mother. You can go ahead and take vaccine. So because if they look at a vaccine literature, it's probably still they have not yet come up to say that you can take. If you look at any of the vaccine, this thing, they haven't yet changed their recommendation. But yes, some evidence have come up.
We should tell the patient what we know. Entire COVID is like that. Nobody can give you yes or no answers. We should be clear as this is what we know so far, and this is what we advise. Things may change in few weeks from now, and then when things change, we will be able to in a better position to tell you. Please do not be dogmatic. Yes or no should not be our way at all, because you have seen what happened over the course of illness. HCQ was a dogmatic thing. Chloroquine, then came ivermectin, then came doxy, then came azithromycin. Now
vitamin C, everything has come.
Vitamin C, vitamin D, zinc, everything we were very dogmatic. Now today we all cannot say that we didn't advise this. So let us not be dogmatic. Let us say what is the current evidence and what is the current guidelines. Only that much. Beyond that, we are not gods.
Agreed. But if a friend calls and says, "Main kya karu? Should I take or should I not take?" What advice, what wording should we use, sir? And this is very common.
So at least vaccination, you can be sure that there is no harm. There is no harm. How much benefit it has, we don't know. But at least there is no harm for the pregnant or lactating mothers.
So even pregnant women, we can say that there is no harm.
There is no harm. But
what you can say
that it will protect them.
At least US and UK guidelines clearly mentioned that it can be given.
Yes,
you have done it.
Yes,
so as far as the friend is concerned, we can say that government will not give it because there is no guideline yet. But overseas it's been used.
Yes.
So now one can give to a child vaccine. So why not? Because 12-year-old child, why do you don't want to give?
Correct.
I mean, these are things which you cannot answer because we don't know. We don't know. There are no studies to say that these are useful in lesser age group children. So there is no data.
Fair.
So one question somebody has asked, if there is a day 7 of fever and RT-PCR positive parents, markers are normal, do we plan to do antibodies in the follow-up? The baby is stable. If the baby is stable, I don't think so.
Why
we
do
need
you
to
want
do
to
antibody. Yes.
Why do you want to investigate if baby is stable?
Yeah.
Academic interest.
And if even if it is RT-PCR positive also and everything is like fine or sick also, then why to do antibodies? RT-PCR is positive. You treat it like a COVID if the baby is sick. If stable, then don't do anything.
The role of
Do you
COVID
want to
antibody.
check to vaccinate or not by looking at the antibodies?
Yeah. Only is if you have a child with presenting like MISC and your RT-PCR is negative, that's when you check for COVID antibodies to say, is it related to your presenting? Otherwise, there's no probably role to check 15 to 20
Let's go.
Yeah. Okay. Uh,
Okay.
Indications of this about remdesivir we have already discussed a lot.
Spoken. I think a lot of questions are on doses and with methylpred versus hydrocot
So I think
or
this,
dexamethasone.
I think the doses are very clearly there in the recent AIMS protocol. Maybe we can put it in the chat or
Yes, yes,
maybe I think Dinesh has answered some of them actually.
yes.
Yeah. Okay, sir. I think so. It's 9:53.
So we have one, sir. I have one question.
Yes.
That a baby born to COVID positive mother. So what is the correlation between baby stable, RT-PCR negative? So any correlation between baby born to COVID positive mother and neck or feeding intolerance? What is your experience?
So as I said already that it is mostly it is related to your top feeding, because if you separate the baby, start giving top feeds, then obviously risk of feed intolerance neck is there. And one can say it is COVID, one can say it is formula. But if the baby is COVID positive and mother is COVID positive and breastfed, if the risk of NEC is there, one can think of any association. But again, this has to be tested with a control group, which we will not have. So these remain in associations.
Yeah, I think someone is repeatedly asking two things. One is inotropes of choice, and other is about enoxaparin.
Yeah. So regarding inotropes, it is you have to manage the baby as per non-COVID. If they are like we had a few sick babies, we managed with adrenaline and noradrenaline because they were very sick. So there are no particular choices of inotrope, particularly in babies with COVID. It has to be like a newborn you manage. And enoxaparin, sir, you please if you can add on.
So mostly it is poor cardiac function, as Mohit said. Most of the time it is myocarditis poor cardiac function. Many of the time they end up being on epinephrine is probably what they do. But as you say, you manage like any other shock to see what they need. But mindful that if they have poorly functioning heart, don't give too much of fluids. Look at their IVC and decide before you push them too much fluids. And keep an early threshold to give them steroids, especially with the COVID-related shock. Is what I in a way. Regarding low molecular heparin, I think I tried to answer that. See, it's a very we're facing the similar thing now. We were discussing one of the cases I was telling you, which is on a Vizag unit. This child has a rising D dimer, but looks clinically well. What do you do? The question: should you go ahead and give the heparin, or should you just wait? So if you have a child, you have an adult, you would probably go ahead and give heparin. In newborn, the data is very limited. When we have with our earlier experience of looking at D dimers in COVID positive newborns, we found that D dimers were very high and they spontaneously started coming down, and we never had to give heparin to any of these babies. So we didn't have to use heparin on any of the babies. So that has been our experience in the first wave. The second wave, as I said, it has not hit the Telangana or Hyderabad yet very hard. I'm not sure if any of maybe Ashish or Mohit or someone from Delhi, if they can answer. If they are seeing someone with bad thrombosis, or I heard someone saying that there are thrombosis in the coronary vessels and other. So if you're having rising D dimers or very elevated D dimers, maybe the reason why you think about enoxaparin, or if you have documented some thrombosis when you're doing Dopplers, could be the reason, is what I would say. But I don't think there is any reason when to start any of the recommendations. It's open to anyone else to
Yes, sir. Like we had that twins in which one twin expired. They presented with hypernatremia and very high creatinine and this thing, and functions were low. they had thrombus and all that stuff, but we baby was in DIC. So we didn't give that because then the baby developed IVH also. But now baby is fine, but they develop IVH. So we didn't give that. We gave IVIG and steroid. Now the baby is much better, going to be extubated. So we haven't used that low molecular weight heparin in these babies, sick one. Just because IVH was our main fear in these babies.
My both babies had also raised D dimer went to 1600 in both around 1500 in both the babies. But the moment this is started inflammation started coming down without use of normal heparin, D dimer also improved, and there was no renal thrombosis before discharge. The renal doctor was also done, and no signs of any thrombosis anywhere. So I think that one need to wait if the things are settling down. No need to use these drugs, particularly in newborn population where IVH is always a high risk.
Yeah. Sir, it's 10 o'clock, I think. So we should, there are so many questions still. I know there are a lot of unanswered things. Should we stop? It's already 10 o'clock. It's 2 hours. I'm really happy with the involvement of all the panelists and the people who are attending. Still 250 people are still there. uh, should we take a last question and stop? Is it fine?
Go ahead.
Okay. Snehal, chal, tera last question. Unmute kar, unmute.
एक ही question है. Any role of plasma therapy like adults in neonates?
Yeah.
I don't think we have data or anything. Whatever the judges, the panelists.
In one of the unit in which Surat, when this baby preterm baby who died expired, they used like it was in the newspaper because the plasma which was given to the baby was of deputy mayor of the Surat. She gave the plasma, and that was being given, but baby died. So I don't know it was of any use or not. Baby was given remdesivir, IVIG, plasma, everything, but in the end the baby died. So I don't know if
it seems that Surat has got a different strain itself.
Yes, that's why, sir, we have contacted. Sir, that's why we have contacted NIV, Pune. We are in touch with them. We have already sent them the samples for the strains and this thing. We are
okay, great.
We are in contact with them. Yes, because I strongly feel the strain in Surat is somewhat very awkward.
This is not that we see in Ahmedabad, and I'm sure Parag you also will agree with me. This is what we do. We don't see this much of lethal variant of this or mutation of this virus in Ahmedabad. We have cases, but not like what you are describing.
So because our babies, like in one baby, we did peritoneal dialysis also because creatinine was 7, opening creatinine was 7, and sodium was 180. With totally collapsed
was that
IVH.
related to other problems or only it is COVID?
The baby was totally fine. Just presented with positive history in the family, 2 days fever, and when presented was totally dehydrated in shock. And FS was just 5%. Heart was just like this, LV.
I think what we should do is, I don't know if Dr. Devadi sir is still there, but through the NNF, we probably should make a clear distinction between what is mild, moderate, and severe COVID in newborns, and then have recommendations about when we should consider these drugs, because I think the role of things like plasma therapy and other things is really in a very, we can't give recommendations. Yeah. So unless we describe, because even in adults, it is used only in the severe cases, as has come in the AIMS protocol. So if you have a clear recommendation about what is severe COVID, and then start using it there, that probably is there. Otherwise, we'll start having problems because of the treatment rather than because of the disease.
Yeah.
And as Ashish has been telling, see the one which you are telling, because now the summer months, the child having COVID, fever, reduced intake, poor cardiac function, will have secondary hypernatremia, renal failure, and will land up with that. And that is how it would be. So we might have different types of presentations coming of COVID, which is sort of primarily has caused either a myocardial involvement or fever or a pneumonia, but secondary problems because of other aspect which we normally see in newborns. So the other aspect of our neonatal management should be very similar like what we do. is what probably I think, because we had a very similar case last year where we had a child with hypernatremic dehydration and renal failure. And when we did a COVID test, it came positive. But with PD and other things, the sodium slowly settled down. And that's how, they're quite sick ones.
Sure. So I think so we should stop here. It's already 10 o'clock. We are
Yes.
past 10 o'clock. So Vardhan.
Thank you, Mohit.
Yes.
Thank you, Vardhan and
Sir.
Dr. Snehal, please.
Thank you very much for
Thank you, Mohit,
Yes,
coming
sir.
on such a short notice.
for nice guidance. Thank you very much.
Yes, thank you everyone. Thank you very much to all the panelists. Like we have gems of neonatology from all over the India. As this topic was totally unexplored, untouched, and everyone was trying their level best. So whatever we are getting from you, it's very helpful for us and other neonatologists and pediatricians. So thank you everyone. Thank you very much.
Thank you everyone for being there.
Thank you, Gujarat. Thank you,
Bye
Mohit.
bye.
Thank you,
Good
everyone.
night.
Good night.
Thank
Good
you
night.
everyone.
Good night.
Bye. Good night. Good night.
Bye bye.